So we're going to just start, actually, I think, dead on time. A lot of people will be joining us as we go along. As I say, my name is Cian Aherne. I'm CEO of Alcohol Action Ireland. This webinar, Joining the Dots, is the first in a series of events and activities that we have this week in our annual End the Silence Week. It's an awareness week which is drawing attention to some of the issues that arise from parental problem alcohol use, something that we know is very widespread in this country and very much related to the fact that we have a very high level of alcohol use. This morning we'll be hearing from a number of contributors. Christa McCutchen is our first speaker this morning, and Christa will be drawing attention actually to the scale of the problem that would be there. We'll be following that up with a talk from Dr. Cian Aherne, who's a clinical psychologist with Jigsaw, and Cian will be really, I suppose, looking at the interventions, some of the approaches that are useful for the children that we know who are living with this particular issue. And we'll move on then to Professor Trevor Spratt, who's just recently retired from Trinity College Dublin. And Trevor will be talking about the impact of, one good adult. But holding us all together this morning, we have our chair of the event, Dr. Niall Muldoon. And we're very honoured, Niall, to have you here. Niall is the Children's Ombudsman and has a long association, with looking at, the issues that are there for children. We know ourselves that at least 200,000 children right now are living in homes that are impacted by alcohol problems. And this is sadly one of the most hidden aspects of the harms from alcohol. Sometimes when we talk about harms from alcohol, people think it's, street disturbances, which of course is theirs, may be very visible, or they may relate it to perhaps, illnesses that would arise, liver disease, that would be there. And these are things that are visible because, sometimes they involve services that are out there. But the children, who are growing up in homes experience, I think, an awful lot of harm, but in ways that are often invisible. And in fact, we'll have another event later on in the week, which is actually called the Invisible Victims, because while we live in a society which is absolutely saturated with alcohol marketing, we're sold a picture really that alcohol is everywhere, but we're sold a picture that it's comes without problems, and in fact that its presence enhances whatever occasion, whether that's a sporting occasion, whether that's a birth, whether it's a marriage, whether it's just an ordinary night out or an ordinary night in. Somehow alcohol has been perceived as being essential to making that occasion be better. But for the children who live in situations where alcohol is really an issue, that's simply not the case. And there's evidence from multiple different jurisdictions that tell us, it gives us, kind of a picture into that. One of the things that we've been doing over the last 3 years in Alcohol Action Ireland is that we have an initiative called Silent Voices. And Silent Voices is very much trying to give voice to those experiences, both of children, but also of the adult children who are growing up in this particular situation. Silent Voices has a platform which we call Shared Voices, where people actually share their stories. And one of the things that we have done over the last few years is to analyse those stories. And it's amazing to see both the individual nature of the stories, but also the commonalities, the things that are just keep coming up, where people talk about the fear and the anxiety, the uncertainty, but also very often talk about how people knew but did nothing, or said nothing, or kept silent about it. So this week of activities is really about trying to end that silence. One of the things that we have done this week is to launch a new policy document. And the focus of that document is to give voice to that hidden harm that's out there. We've put forward a number of suggestions, and we'll be talking about that in a little bit more detail. But essentially, we would be saying it's time for us to join the dots, to try and make different services understand and have knowledge of where do children fall within that. So that could be, maybe a parent is perhaps getting, treatment, alcohol treatment, which is fantastic if they get that. But where do children fall? Is the question being asked? Where is the service for that child? Are they able to get that help in their own right without their parent perhaps having to actually go into treatment? Or it could be, that intersection that we often see. Sometimes we'll see problems between, an alcohol problem, a mental health difficulty, and maybe domestic violence. So if we have a domestic violence strategy, where is alcohol within that, and where are children within that particular strategy. And I think what we're trying to do, and what we hope to maybe do in this event and through the other events that we have during the week, is to join those dots together. So that's kind of what we're hoping to get out of that. But really what helps us enormously is when we have that input from both people who visit our website, who come to our webinars, who interact with us lots of ways. This is an opportunity for us to hear from yourselves. So we're very, very anxious to have questions. Please feel free to stick any questions you might have into the chat box, and we'll get to that at our panel discussion at the end. And at that panel discussion, we'll also be joined by another colleague from Fiona Coyle. Fiona is the CEO of Mental Health Reform. And one of the things that I know that Fiona will be doing for us is to try and piece together some of the actions and some of the discussion that we're having there within that mental health framework as well. So we're very much looking forward to welcoming you to that. So that's my preamble done. That's just what I wanted to say at the moment. Niall, I'm maybe going to hand over to you at the moment and let you introduce our speakers and keep us on the straight and narrow with the time as well. Thank you.
Great, thanks a million, Sheila. Good honour for me to be here, to be involved in sharing it, and with such a distinguished panel as well. There's a lot of areas that I'm really excited to hear about. I suppose a little bit just from my point of view as Ombudsman for Children, I mean, children's rights are obviously the key focus of our office, and children's rights are impacted in so many ways by alcohol. The fulfilling of their rights is damaged in many, many ways. I think one of the pieces that really struck me is, struck me since Silent Voices came into being, the concept of silence in Ireland has been very strong. You know, we've always been shamed into silence, we've been feared into silence, but staying silent and trying to hide your problems has been, it's a national pastime. Certainly I would have grown up in an era when you did not let anybody know your concerns at home. You did not let anybody know. You did not interfere with them if you had thoughts or fears or concerns from the neighbours or the neighbours' children. And it's something we need to move away from, you know, because silence is ultimately toxic. It's where pain comes from. It's where it drains the energy. It means you have to hide. It means you have to lie. It demeans you. So it's something, again, alcohol just brings that about, that sort of fear of children to say, well, I can't say what's actually going on in my home. I have to pretend. Same with adults. So it's, again, I think it's very important when you look at them from a rights point of view, how that can harm the child. Very simply, you know, if there's alcohol abuse in the home, then the home may not be as safe as you want it to be. So the child isn't growing up in the safety that they want. Their access to education may be hampered by parents or family members who may make it difficult to get to education or to enjoy your education or to fulfill it properly or to do your homework, even just simple stuff. Access to play, those small things, you know, the extracurricular stuff may not happen because of alcohol. So just there's a whole range of things. So just sometimes people ask me why I'd be involved in this area. And I think it's crucial that we just recognize that anything that hampers the child's fulfilling of their rights needs to be worked on. And again, the theme for today, joining the dots, is crucial. You know, there are many people who know about it, but individual cases, professionals involved in children's lives, family members involved in children's lives, that we need to start helping to come together to break that silence. Again, small things, you know, if a child actually becomes addicted under 18, access to services, to their therapy, to addiction treatment is very, very limited across the country. So that's something that, you know, services need to look at and see, can they do something better? Obviously, then it can be better services for the adults as well. And then finally, just and I know Sheila will probably talk about it in depth, but the Operation Encompass is something that I've been pushing very strongly. In England, it's very clear that in, I think, nearly all of the individual police authority areas in England will notify schools if they've had a domestic violence situation and just say there was an Operation Encompass event last night, and the teachers then in school are able to deal with that in an appropriate manner. It may mean doing nothing major, but it might just also mean putting your arm around the child and saying, listen, don't worry that you don't have your homework, or we'll get you your lunch, or whatever. I think that's something we could very easily bring into our schools, and it's something that I think has been promised by Minister for Justice through the Domestic Sexual Gender-Based Violence, and I hope we will see it in action very, very soon. So that's me. I'm going to move on, let the real speakers come in. I'm going to introduce you first to Dr. Christa McCutchen from Maynooth University and part of the Department of Psychology there. We've done an excellent piece of work really outlining the current level of issue around alcohol in Ireland and the scale of the problem within the Irish population. So it's the most up-to-date we can have and compared it with mental health issues in the United States as well. So I'll pass over to you, Christa.
Thank you so much. Sorry. Okay, hi everyone. So my research interest is ultimately developmental trauma and the impacts of that for children growing up and the adults they become. And my research project is on adverse childhood experiences, and it's an evaluation on them in various ways. The first paper that I published was the one that I'm going to be talking about today, which is just evaluating some samples from the United States and Ireland. And we're doing some other things, kind of evaluating ACEs as a measure. And, you know, getting into this research work, my ultimate goal is to try to provide information for those who are policymakers, those who are going to take this information and put it into action. And so I'm really honored to be presenting this research. This is my first time presenting it and personally presenting it in this way. So I'm just really happy to be here, and thank you to the organizers of the event today. So I just want to start talking about adverse childhood experiences as a whole. So a little bit of background on ACEs. In the late 90s, a medical group called Kaiser Permanente and the Center for Disease Control got together and had patients fill out a survey, and it included things about their health. And then they also in the survey had included things about household dysfunctions, adversities in the home, which were on the screen right now. They had different forms of abuse, neglect, and things that have been categorized as household dysfunction, which is substance abuse or alcohol abuse, domestic violence, witnessing domestic violence, divorce, incarceration, and mental illness, and suicidal ideation in the home. And so they were surprised with the levels of association between these things and these health outcomes, because they can have different behaviors and affect things like physical health, things like obesity and heart disease and things like that. And they also found depression. So this research sort of blew up in the United States, and there was a bunch of research that came out about adverse childhood experiences. And I checked yesterday, and actually the original study, as of yesterday, has been cited 20,772 times. So it's got a lot of wide appeal. But when I started this project, actually there was not an adult sample for the Irish population. There was some elderly and older adults, and there was some evaluation of children and adolescents, but not a full adult population representation. So I just want to say really quickly, as Sheila touched on, there is a lot of crossover of these things, which is sort of why they're usually measured as a whole. So, you know, substance abuse is connected oftentimes to other things in the house. So these kind of cross over, but I will be doing some looking at each individual and sort of them as a whole as well. So the paper that I published is the occurrences and co-occurrence of ACEs and the relationship to mental health in the United States and in Ireland. So we had the adult samples from the United States and from the Republic of Ireland. The first thing that we did was compare the differences in occurrences of ACEs in the US and Ireland. Then we also looked at the associations between ACEs and major depressive disorder, generalized anxiety disorder, post-traumatic stress disorder, and complex post-traumatic stress disorder. And we also examined the dose-response relationship between the number of ACEs and each diagnosis. So this is a graph from the paper that is the frequencies of ACEs in the United States and Ireland. Ireland is represented by the green and the United States by the blue. And the asterisks are statistically significant differences. So for any ACE, so just experiencing one of any of them, Ireland had 65% of the participants who had experienced any, which was statistically greater than the United States. They were also greater in verbal abuse, physical abuse, emotional neglect, physical neglect, and someone in the home being mentally ill or having a suicide attempt. So they, for problem drinker in the home, they're almost the same for both countries at 25%. But one limitation that I want to quickly point out in this study is that ACEs, the particular questionnaire that we used, was it's a yes or no for each 10 items. So the alcohol question is, it was someone in your home a problem drinker or drug user? And so there wasn't additional questions about frequent, like it basically depends on the person filling out the questionnaire and their definition of what a problem drinker is. So you, it's just not as exact. So I would guess that it's probably a bit higher than what we found. I would lean towards the underestimation of what's a problem, but you know, I can't say that for sure. That's not within my research, but something to think about, because this is an overall view of ACEs, and that question, if it had been a survey that was about that particular topic, it would be probably a lot more in depth, but that was the question that we asked, and these are the results that we got from the question. So this is a graph representing the associations between ACEs and major depressive disorder, generalized anxiety disorder, or PTSD, and CPTSD. So if you look at the problem drinker in the home item, oh, and we controlled for nationality, age, sex, and highest level of education. So this is, regardless of all of those things, these are the outcomes that we found. So anything over the 1.50 line is statistically significant. So the two items for problem drinker in the home that are statistically significant are PTSD and CPTSD. So having a problem drinker in the home, a person would be 1.71 times more likely to have PTSD and 1.91 times more likely to have CPTSD. And this is just the graph showing our dose-response relationship for the ACEs. You'll see that there is an increase the more that people have. There's a little bit of a steeper increase once it gets to 4. And in particular, the CPTSD, it has a great increase at 4, and it's almost 16 times more likely to have CPTSD at 4 ACE events. So just a few things to go over for our notable findings. We did find, so in this first analysis of the Irish population in adults, we found that Irish respondents were more likely to experience multiple types of ACEs, and we also found that that the population qualify for a diagnosis of MDD, GAD, and CPTSD than the United States respondents. It was more PTSD in the United States. One of the more significant findings is living with a problem drinker or drug user was found to be significantly associated with PTSD and CPTSD. And I also just want to point out that in doing the research for the research, there was a particular study that I cited in the paper, which had 9,282 participants whose parents abuse substances. And for this study, they found that those who experienced that in the home were 2.5 times more likely to qualify for substance abuse disorder and 2 times more likely to qualify for some of the disruptive behavior disorders. So that is my research, and I just thank you for having me, and thank you for listening to my presentation.
Thank you very much, Christa. That's fantastic. Can I just ask a quick question just before I move on to Cian? What's the difference between PTSD and complex PTSD, just for people?
Okay, yes. So PTSD is a disorder where you have a certain criteria that you have to meet to have a diagnosis. There are things like re-experiencing and some other items included in that. And then in order to get a CPTSD diagnosis, there are additional symptoms that you have to have. So you get a diagnosis of PTSD and then continued with these additional items that have more to do with, so the PTSD are more about kind of re-experiencing traumatic events. And then the CPTSD has things that are more about kind of getting along in the world and like relationships and things like that. And so CPTSD has been tied a lot to more long-term trauma rather than, and you can have PTSD with long-term trauma, but rather than that short-term trauma or traumatic event, it's sort of stretched out and happens a lot in child abuse situations, and was just recently added as an official diagnosis in the ICD-11. So in the last version of the ICD-11, it was included as an official diagnosis.
That's great. Thanks, Amelia.
Thank you.
Thank you very much for that. Great thought on that. Cian, Doctor, we're going to move on now to Dr. Cian Aherne, who's a chartered clinical psychologist and a clinical manager in Jigsaw in the National Centre for Youth Mental Health in Ireland, based in Limerick. And I was Cian speak last week only, and I know it's going to be an excellent presentation and very, very important stuff for the connection with the young people that we're working at and the way we address problems. Thanks very much, Cian. Pass over to yourself.
Thanks, Niall. Yeah, I'll just share the presentation here. And thanks, Christa. Thumbs up if that's running all right. Yeah, does that look like? Perfect. Yeah, so my name is Cian. I work with Jigsaw. We are, as Niall mentioned, the National Centre for Youth Mental Health. I work in the local service in Limerick. And I feel a little bit awkward today in that my presentation is about giving young people a voice, whereas I don't actually have a young person with me to elevate their voices further. And usually that's what I would do. And I did invite some of our youth advocates locally to co-present with me, but there wasn't anyone available to do that today. At the same time, when I talk to young people and I kind of mention about being in spaces like this and wondering whether it should be my voice that is being heard or whether there's a different way to go about presenting some of these issues or talking about young people's voices, the young people I have asked have said, look, you're in a position where you have the privilege to do this. You have a platform that we don't have. And it's really good for us actually that you will kind of stand by our voices and elevate them through the presentations that you do. So that's what I'm trying to do today. And you'll see that hopefully filtered throughout the presentation and the slides are the young people's voices that we actually work with from day to day as well. So I will also be talking about a framework today. And it's interesting that Christa talked about ACEs and CPTSD there, whether it's the ICD or the DSM, where people are given diagnoses of disorders or things like that. The framework I'm going to talk about today is actually probably a bit of an alternative to that, and trying to understand the context of people's mental health and And sometimes it's just a matter of wording, but looking to maybe move away from words like disorder and move towards things like function and understanding and making sense of. So that's just a bit of a backdrop to what I'll be talking about. I think it's helpful maybe to give a bit of context to the service that I work in. So we're a youth mental health service that is based in several counties across the country. So we're not fully nationwide, but I think there's about 15 services, as well as our online service that is available across the country to any young person aged between 12 and 25. The local services offer one-to-one talking therapy. The online service, it's kind of instant chat therapy that's available to anyone who may need it. And we do a lot of work in the community at events like this, or events in schools, or in other organizations or things like that. So Jigsaw is an organization that is informed by being young person led. So as I mentioned, we have youth advocates attached to every service and nationally as well. Youth advocates are young people aged 16 to 25 who have an interest in mental health and who also have a kind of a passion and energy for having their voices heard and informing our services. So they will meet, our youth advocates in Limerick meet approximately once a month, and they will reflect on questions we might have about the service and offer guidance and recommendations as to how to keep our services relevant for young people. So always trying to have their voices heard in all that we do, whether it's about how we offer therapeutic services or how our offices look to the young people that come to our doors, or where we are at tables regionally or nationally, government spaces, that we have young people with us, and that their voices are being heard in advocating for the youth of Ireland. Our services, we try to ensure that they are collaborative, so that anything that we do, whether it's in therapy or projects or things like that, that it is done with a young person, that we don't do our services, we don't do them to young people, we do them with young people. So at all times, trying to take a step back and really listen to what a young person has to say, and be really curious as to how they can influence their own service. And that's something that I'll talk about throughout the presentation, is having a sense of collaboration, curiosity, humility, and knowing that at all times we don't know what it is that's important for the young person. We don't know their full truth. And to really understand their perspective and to really hear their voices, we need to actually listen and actually accept that at times maybe we don't have the answers, despite our certainty that sometimes we feel we do. Our services look at things from a systemic, multi-contextual perspective, which Sheila kind of alluded to earlier, is that we look at the impact of things on young people. So what has happened to a young person rather than what is wrong with them. So rather than looking at any internal deficit of a young person or a lack of coping skills or that kind of a language, instead we consider, well, what's happened to this young person that makes sense of how they might be behaving or how they might be responding. And underneath all of this, how does it all make sense actually? And why might a young person be responding the way they are to whatever level of trauma or stress that is going on in their personal lives or at home? So at all times trying to pay attention to their own subjective internal world and to how they perceive the external world. So we're a non-diagnostic service, so we're not a medical service. We don't do assessments and diagnosis, that kind of thing. The general ethos to our work with young people is around hearing their story and helping young people piece together their story in a way that makes sense for them. But just a couple more administrative pieces. So it's a service for 12 to 25-year-olds. We're a free service. A young person can refer themselves, a parent can refer a young person. or a GP, teacher, professional can refer a young person. We try to have as little barriers as possible. So they can be referred via email, in person, via the phone. And we offer what's called a brief intervention as well. So that is an intervention that probably lasts over the course of maybe 3 to 4 months. Some young people only need 2 or 3 sessions. Some people need 8 to 10 sessions, but it is a brief intervention. So young people accessing our services, their support is time limited, but we do try our best to meet the needs of the young person, depending on what they are. Now, to talk a little bit about this framework that I've kind of introduced, it's called the Power Threat Meaning Framework. Those words, to me, didn't particularly make sense when I first heard about the framework. It sounds a bit daunting, power and threat and all of that. When asking young people what they took from kind of reading up on this framework and what makes sense to them in the room, the kind of tagline they came up with for it is that the basic tenet is that people's responses are understandable. So if you're thinking Power Threat Meaning Framework or the PTMF, the basic understanding of it is that people's responses are understandable. The framework is made up of 4 questions. They're fairly straightforward questions, but there is a real depth to how we respond to them and to how young people respond to them as well. So the questions are: what has happened to you? How did it affect you? What sense did you make of it? And what did you have to do to survive? And those questions don't need to be asked in that order by any means. You can kind of go from one to the next and up and back and around. It's whatever kind of makes sense to you or whatever is coming up for you, or in this case, we're talking about young people, what's coming up for them from session to session. And this framework was developed and published as an alternative to those previous models of the DSM or the ICD, that this actually can give young people a narrative and a story that they can make sense of. So rather than a kind of a symptoms and categories, we talk about what has happened to you and what have you had to do to survive. So that question of what you've had to do to survive, that might previously have been referred to as what are your symptoms. Instead, we're looking at, well, what are your threat responses? How have you responded to the threat or the stress or the trauma in your life? And what function do those threat responses serve? So it's very different. It's a change in our thinking, a change in our narrative. And again, the most important probably change from it is that change from what is wrong with you to what has happened to you. So really trying to bear that in mind at all times. And when you think of the young people that you come across, and all that has happened to them, and how still there can be a kind of an allure towards considering, oh, there must be something wrong with them, or they mustn't be coping properly, or they don't have enough resilience, or that kind of thing. Actually, if we can kind of step back from that for a minute and think, well, hold on a second, maybe this is quite a natural response to a really traumatic situation at home. And when it comes to problem alcohol use, that can be associated with a lot of chaos, a lot of danger, and a lot of stress at home as well. So a young person not knowing maybe from day to day what they're going to be coming home to and what the general mood or the general response they're going to get as they walk in the door, considering how they might respond to that or how they're going to protect themselves in such a situation. And sometimes it makes a lot of sense actually to consider, well, maybe this is quite a very understandable protective behavior. And we'll get into that in a little bit as well. So we do have a booklet that's on the PTMF website. If you type it into Google, freely available. This is a booklet that we use in session with young people sometimes. Now, some young people aren't mad about booklets or writing or things like that. So when that's the case, we kind of step back and just consider the questions for ourselves maybe and trying to understand what's going on for them. But sometimes it can be really helpful for them to take away a sheet like this and consider their story and consider the impacts of what's happened to them. So again, in the interest of trying to elevate young people's voices, we've taken the questions to young people and asked them, well, if you could ask that in the language of a young person, what might it be? So when they looked at the question, what has happened to you, they elaborated on that a bit and said, well, it's really what's happened to you or what's been done to you that has been unfair. I think you can probably picture immediately when there's, problem alcohol use in the home, what kind of things are being done that young people would find traumatic or unfair. How did it affect you? Young people saw that as addressing how did it affect your emotions. So really considering a young person's feelings or emotions, whether it's anxiety or sadness or confusion, things like that. And then what sense or understanding did you make of it? And we'll see in a while, but what young people often seem to take from their experiences in the home like that is that actually it's their fault. And so many young people come into our services thinking that what's going on at home or what problems there are at home, the sense they make of it is actually it's their fault in some way, that they're not good enough for the parent, or that their parents are choosing alcohol over them or things like that, and that that general sense that they'll never be good enough or that they're not fully loved or that kind of thing as well. So again, just piecing that together bit by bit with the young person, trying to put together a story with them, seeing what makes sense to them, offering them, you see under the questions, a whole load of examples of answers that they might want to choose from, or they might have their own as well. And then considering that question, instead of what are your symptoms, what have you had to do to survive? So again, historically, we might look at things like self-harm or eating restriction or compulsions as symptoms, whereas if you look at it from the perspective of this framework, actually those things can serve a really important purpose for a young person and can actually get them through a really difficult time. So, for example, self-harm might offer some level of emotional regulation. Restricted eating might be the one thing in their lives that they can control in a world that is full of things that they have no control over whatsoever. Maybe the restricted eating is the one thing that they have a bit of control over. So trying to think about it in that way, really trying to reorientate ourselves to considering, okay, well, if this made sense, what might the purpose of this behavior be? So taking a step back and considering it that way and really trying to understand it with the young person is where the framework and these worksheets get to. So the other worksheet we have, it really looks at the functions of these threat responses. So I know we're not going to get through all of these today, but like I said, you can access the booklet online to have a look at these. Young people really can connect with a sheet like this where they can highlight the different types of threat responses that they might engage in and then highlight the needs that might be being met. It's not always a kind of a match from column to column, it's about exploring this with the young person and seeing what connects for them. So like I said, there's a few pieces there that we may not recognize if we kind of look at it as a internal deficit or a disorder, instead of trying to look at the need being met. And then once you look at it this way, you have a chance or an opportunity to delve a little bit deeper with the young person and help them piece together their understanding of, oh, so that's why I'm so angry all the time, or maybe that's why I'm so aggressive when it comes to people in authority. It's because I've never had a person in authority who I've been able to trust in the past. So my trust has been betrayed throughout my life, and anytime I have trusted an adult, it's come back to really hurt me. So it may make a lot of sense to be always on the defense, or to find it difficult to trust. And so when we take on the ethos of the framework and we look at trying to understand what's going on for a young person, you'll see that our language starts to change. Our perception of what's going on for them starts to change. So where you might see someone who's been affected by alcohol at home, historically seeing their behavior as unacceptable or avoidant or defiant or aggressive. Instead, we start to recognize that well, actually that behavior is quite understandable, and maybe they are in flight or survival mode, and that they're coping with threats at all times. So why would your presence or your input be any different to any other adult in their life? And that oftentimes that's when you think of how did it affect you, that question on their emotions, oftentimes we're seeing that it affected them by making them really anxious and scared. Just a further few examples of, rather than looking at it as attention seeking, we're talking about attachment seeking. I always think about that, like in terms of attention seeking, really, if someone's attention seeking, it's because they haven't received enough attention, you know? So it makes a lot of sense that they might be looking for further attachment or supportive kind of closeness with an adult. And then again, instead of withdrawn or rude or not engaging, we're changing the language to cautious or self-protective, or just not feeling safe just yet. And I think that's the part of it. It requires a level of curiosity and patience from us as well. And us being the strong kind of adult in their life who doesn't get bowled over by the difficulties that they might be bringing our way, or doesn't get angry or reactive in response to some of the behaviors that we might be seeing. And again, that's not to say that us as adults are going to be perfect all the time as well either, you know. When I think of these kind of examples, I think of my own children, and there's always that kind of feeling of you really want to react and say, "What the hell is wrong with you?" or that kind of thing, you know. When it's about trying to catch that, sometimes you might say it, and that's okay as well. But trying to catch it, take a step back and say, "Okay, I'm the adult here. Take a breath. I know that what's going on here is really having an impact on my emotions. So maybe I need to just take a break for now, come back to them in an hour's time, and when things are calm again, and try to reconnect and show them that no, I am interested. I am here to listen. I'm not here to try and solve the problem. I'm just here to be with you in it." Because I think a lot of the young people that we're talking about here, you know, they have so many adults and professionals really earnestly trying to come in and solve problems or fix things for them, when what they're calling out for, what they really need is just for you to sit with them and to connect with them emotionally and to tune into how they're feeling, rather than to be trying to solve any of the problems that they might be experiencing. So just to talk a little bit further about the PTMF and the way we bring these concepts into the room with young people. Again, Sheila kind of talked about it earlier, the kind of common conception in Ireland that, you know, alcohol is not problematic, you know, it's a real necessary thing for celebrations, or, you know, it's a very normal thing to have at home, is that, you know, drinking at nearly every event or that kind of thing. And what we're trying to do in sessions, whether it's around our ideology around alcohol or any other issue in society, is understanding that ideologies hold big power, you know, and they have huge power to impact on our emotions. And the normalization of excessive alcohol consumption has actually had a majorly negative impact on our emotions. Then the cutting off of emotions, the trauma that comes with alcohol abuse at home as well, and the impact that that has on the children who are exposed to it. So this worksheet is about, you know, just shedding a light on some of the messages that we get from powerful systems, whether it's the media, government, our neighbors, our peers, trying to normalize something that really actually may be having a superly negative impact on how we're feeling. And that goes into the what has happened to you question. You know, sometimes what has happened to you is a very obvious trauma at home, whether it's a physical abuse or an emotional abuse on the back of alcohol use, Or maybe it's just the normalization of alcohol in the home at all times, and that's actually the thing that has happened to you that has had the negative impact on your emotions, is this kind of sense at home that it's okay to be cut off, that it's okay to be distant, it's okay to, be out every night of the week away from your children, or that kind of thing. So that question, what has happened to you, the answer to that can come in many different guises as well. So just bearing that in mind. And just I have an example just to try and illuminate the questions of the framework. It's not necessarily related to alcohol, but it does hopefully show how the questions can get to the heart of a challenge or a difficulty. And it's also a good example of something that's been co-created with young people and filters their voices throughout. So it's a research paper that is available freely online in Clinical Psychology Today. If you type that in, and Society's Anxiety is the name of it. But I wrote it up with a colleague of mine and two youth advocates from Jigsaw Kerry in Limerick, where we were trying to consider young people's anxiety in Ireland, and to consider why there seems to be this trend of rising levels in anxiety across the youth of our country. So we wrote it up together and also consulted several groups of young people to have their voices kind of filtered throughout it as well. And we used that power, threat, meaning framework, those four questions, to try and consider, well, what's going on in society that's having this impact. So when we looked at what has happened to you, young people said that there is the powerful message that achievement, perfectionism, performance is the means to living a successful life, and that puts pressure on young people to perform at the highest level in all that they do. And you can see that trying to connect that with a background of alcohol, is that sense of having the perfect home, having the perfect family, that there's pressure to be seen, to have all of your ducks in a row, and to have this life that is a kind of a cardboard cutout from TV or whatever. How has it affected you? Individual identities are constantly under threat, with the need to fit in being constantly to the fore. And we see rises in anxiety, confusion, low mood, and the breakdown of family and community. And what sense have young people made of it? And this is what I touched upon earlier, but that young people are often seeing themselves as the ones responsible. We're the problem. We're the ones that are at fault for all that is going wrong. Because that's what the adults keep telling us as well, What did you have to do to survive? So much challenges across the country with self-harm, poor sleep, refusing to go to school, anger, difficulties with eating. And hopefully I've kind of illustrated throughout the presentation so far that we can now see these as very understandable responses actually to the traumas that young people are experiencing all the time. And that, we can really make sense of these as responses rather than just young people being difficult or not coping properly. And what are young people's strengths? So really incredible creative talents, hugely caring spirits with vast amount of energy that are looking to put into meaningful ways of living. And the power of connection also being a huge strength. So young people are really sticking up for themselves through social media, through protests, whether it's, Fridays for Future and climate activism, or, in public spaces, standing up for themselves in general as well, and being at government tables and things like that. And then what is your story? So young people have said, we get a lot of blame. This has made us angry. And as a result, we are standing up for ourselves with strong opinions and loud voices. So hopefully a good example of how the framework can kind of bring some of these issues to life and delve a little bit deeper into the context and the sense making of young people's emotional challenges. So just to finish my presentation, when we're thinking of how do we spark a bit of change when it comes to these things, I'd say try to use that framework on yourself. Just pick an example from your own life. Ask yourself those questions. What's happened to me? How did it affect me? What sense did I make of that? And what did I have to do to survive that time? And that will lead to a deeper understanding of why these questions are actually helpful, what kind of light bulbs get set off. There's a lovely book, A Straight Talking Guide to the PTMF, if you want to delve a bit deeper into some reading. It's a really accessible format. And then just thinking how we talk, what we write, how our general kind of approach to young people is. Do we have that curiosity and humility, or do we tend to approach things with a kind of assumption that we know the answer beforehand? Because it is about collaboration, and the only way you kind of connect with a young person is by taking that step back and really taking them seriously, actually. So just keeping those questions in mind, and that's the bit that I'll finish with today is, if you take nothing else from the presentation, it's changing that internal question of what is wrong with you to what has happened to you. And that really opens doors that you may not have considered before as well. So thanks for that. That's me.
Thank you so much, Cian. Again, fantastic space, fantastic talk, and really important. Look at it from a different direction. Again, I've taken down, if you just ask our young people, I mean, calling themselves hugely caring spirits, I mean, so much can be done with that if we allow it to come out and allow them to express it. Incredibly creative talents. Again, what gets lost, what gets covered up when things go wrong in the household, and whether it's alcohol or other issues. It's just great to be reminded of that, and also that ideologies hold big power. Again, we maybe need to reflect on that as a society as well. So thank you so much, Cian. Well done. I'm going to move on then to Professor Trevor Spratt, who's newly retired, and again, great example of retiring early, obviously, Trevor, and looking well.
Oh, I wish.
Thanks for coming back to us. Formerly with TCD and professor in childhood research there, and he's going to follow up in a connection with some of the work that Jigsaw have done around One Good Adult, and just look forward to your piece as well. So thank you very much, Trevor.
Okay. I'm immediately having a problem in sharing. It's directing me to system controls here rather than
So Trevor, if you want, I could share it from my screen.
That would be great. It just hasn't come up. So
okay.
And if I just say next, can I change it from?
Unfortunately, I don't think you can. So if you just give me 1 wee second when I get this myself. On that. I do apologize actually, because it just
This has happened to me once before, and it was when I got a new computer, and this is
okay.
a computer, so I it's probably some kind of
thing there. Okay, so I'll see if I can get it. One wee minute. So I had it open and ready to go just in case this would happen. I think there it is now.
There we go. Yeah.
You just say next slide, Trevor, when you're ready.
Okay, thank you. Okay, good afternoon, everyone. Nearly afternoon, and thanks very much for inviting me today. It's for about a large part of my sort of academic career, I did look at ACEs, and I did look at child abuse and neglect, and I did look at a lot of the bad things that happen in life and how they may predict bad things happening in later life. So that connection between early experience and later experience. Next slide, please. And it's really about that, how does a child born into the world with all the potential that there is, how do they migrate over the course of their life to this gentleman who's probably younger than I am, and yet he looks, written on his face is a life of difficulty and adversity and struggle. So next slide, please. So a lot of this, as Christa has drawn attention to, is now really well mapped territory. There's been 25 years of ACEs research. I've been involved in a number of studies, and they all say the same thing, that the more difficult your childhood, the more probable it is you will have a difficult and challenging adulthood. And it's not inevitable, but in terms of probability, it makes that higher, that probability higher. So next slide. But the key thing is, I think, to remember that because ACEs are so ubiquitous, many of us have had a parent who might have had depression or had someone in the house who died or left. These are naturally occurring events in the population. So ACE scores, about half the population or more, as Christa has indicated in these recent studies, have an ACE score of 1 or more. So they are there. And most people with ACEs go on to live lives that are successful and happy. However, the fact really about the ACE scores is the dose effect, that the more ACEs we encounter, the greater the probability the challenges and poor outcomes will occur. So a lot of the research then is on to looking at people who have higher numbers of ACEs and those outcomes that occur. So next slide. And just to kind of refocus our minds on what those outcomes are. So physical health, 4 times more likely to develop type 2 diabetes with an elevated ACE score of 4, 3 times more likely to develop respiratory disease, 3 times more likely to develop heart disease. And with very high ACE scores, you're losing about a quarter of the lifespan, people dying around 60 rather than 80. Next slide, please. And of course, the impact on mental health is also well known. So often I draw attention to the opposite end. So if you have an ACE score of 0, you've had a happy and successful childhood without too many problems, your chances of going on to develop a mental illness across a lifetime are relatively low. And I think some of this draws our attention to public policy. Do we aim our public policy at entire populations, or do we target? Do we say, okay, mental health policies may need to, you think about everybody, yes, but you also want to target people who have particularly disrupted childhoods or other factors which might make them more vulnerable. The next slide, please. And I've just picked out one of the trajectory slides here because we're looking at alcohol today, and clearly alcohol is associated with higher ACE scores. You can just see that dose-like effect there on the chart. Again, we live in a society where alcohol is ubiquitous. It is everywhere. It's in the home. It's an events, as Cian has pointed out. But the chances of a person becoming an alcoholic, if they've had a good childhood, are pretty low. They may be an alcohol user, but they're probably not going to be an alcohol abuser. And the person who does abuse alcohol, and as Cian's pointed out, is really a kind of self-medication, which is rational in relation to the difficulties they're trying to cope with in their adult lives. So next slide, please. And there's a number of studies that look at if you've been exposed to alcohol in the home, what is then your chances of developing an alcohol problem in the future. So pick this out because it's a big study involving 43,000 people who were all interviewed in person, unusually. And the take-home message here is experiencing both childhood or adolescent parental divorce and separation. They looked at that as well. And parental alcohol problems had a significantly stronger impact on the risk of alcohol dependence than the risk of either factor on its own. So often we, in our minds, say, well, the parent, the alcohol problem, what are the chances of the child having an alcohol problem? Well, they are elevated, but they're more elevated with each ACE you add. And this is just an example of adding an additional ACE and what that results in. So it's not just like for like, it's the multiple effect coming in here. And that's something we have to be mindful of when we're just thinking of cause and effect in a simplistic sense. Next slide, please. So after about 10 years or so being involved in ACE and childhood trauma research. The last part of my career, the last 10 years, I was really determined to think, well, what can we do to actually begin to help families and children, and what can we kind of develop an evidence base for in relation to effective interventions. So I started really looking at services, you know, traditional services. These are like therapeutic services, and did quite a bit of work with the Daughters of Charity, who many of you will know work in the Greater Dublin area. And they operate a number of services, but two main types, the early childhood developmental services. So these are typically targeted at a community level where there's high levels of deprivation and social problems, and that feeds through into depressed educational performance when the kids go to school, essentially. So these services would help children get school ready. So they're in the blue, and you see, actually, thankfully, these are also younger children, or they're about 4 years old. They have low levels of ACEs, what we call stressful life events here, but essentially ACEs. Contrasting that, if you look at a referral service, these are children who are referred to family centres, typically by social workers, but not always. And these are where problems become apparent in the family, and the children are of school age. So you see the difference in type here: one a community-based service, another referral-led service. Very high levels of ACEs. 45% of these children have an ACE score of 4 or more, even though they're relatively young, most of them at primary school. So next slide, please. We looked at a number of factors using standardized measures in terms of pre and post tests. So we tested people as they went through the services at the start, and then at the end, to see if there'd been any improvement in their profiles and the issues that they were bringing to the table. So you can see these gains are modest, but all in the right direction in terms of the children's emotional and behavioural strengths or difficulties, and that would suggest that there is an impact, a positive impact of these services. These figures represent between 1,000 and 2,000 families, so there's very substantial numbers here, and so we can stand over them with, with a degree of confidence. Pro-social is in the other direction, but you want it in the other direction. They're becoming more pro-social slightly, whereas the other ones are about difficulties that are reducing. Next slide, please. And one of the key things we look at is the child-parent relationship, because often that is the upfront factor that brings them into the service. Things are going wrong. So closeness, they're getting closer, the blue line, the parents over the time frame, that's improving, and conflict is reducing as well. So by those measures, you can see the processes that are going on here beneath the strengths and difficulties results. Next slide, please. Parents' mental health, again, the blue line represents all parents in the survey, and there's a modest improvement in their mental health. But the red line represents parents who came in with very low mental health scores. So they did proportionately better. So in other words, the worse that your mental health difficulties coming to the service, the more they improved relative to the whole population coming in there. So again, a good story, because we know parental mental health impacts on the young people, the children, and therefore this is signals where the improvement is coming from in the relationship scores. Next slide. So those are traditional services, and I think those of you who are here today and attending and who are involved in traditional services, there's real merit in having a look, using as hard measures as you can on the progress of people using your services. Do they achieve gains? Are they coming out better than they went? And you would hope they are. And I would say in the vast majority of services we offer, they are. Whether those are sustained, we don't know. It would be great to come back and test everyone 6 months later or a year later and so on. And that would be the real golden indicators. But we can say for now, certainly good is being done, and we're reducing the levels of stress and conflict within the homes, which will benefit the children. However, are there clues in the literature about what really makes a difference? What are the key things that really make a difference in terms of, if you like, interventions in its broadest sense? And so myself and a couple of colleagues were very intrigued by this result, a very large ACE survey in Wales. Wales have ACEs built into their public health strategies at a fundamental level. It goes all through their services, so everybody is aware of them and measuring them and so on. And it's actually handy to population to compare with Ireland, because it's, it's a little bit smaller, but similar kind of country, similar kind of profile. So these are asking people who have ACE scores of 4 or more, adults who have ACE scores of 4 or more. As a child, was there an adult you trusted could talk to about your problems? 22% who said no were problem drinkers, and against 7% who said yes. 22% who said no habitually used heroin or cocaine, against 10% who said yes. 43% who said no had been to jail, against 10% who said yes. So one of the things that the ACE survey doesn't pick up is, are there mitigations? Are there buffers? Are there things present that actually may interfere in the trajectory so that the person doesn't experience the worst of outcomes when they're an adult? And I think there are real clues here. So next slide, please. What we did was we did a systematic review of the research literature looking at this question. Could we dig out enough from the research literature that might give us answers to, this question? What is known from the existing research about the role and qualities of trusted adults in providing support for children and young people who've experienced adversities? And spoiler alert, these are the 4 key themes that came out. I'll elaborate a little bit as we go on. But yeah, trusted adult support does reduce harmful outcomes. There's empirical evidence to substantiate this. But those trusted adults have to have certain core qualities. It can't be just any adult. And in the terms of the trajectory of the relationship, the trust in that adult needs to be built up over time. It is not an in-out thing. It's not a therapeutic intervention. It's more a relationship that's established. And trusted adult support can come from a range of sources. And I think actually I was saying that earlier, the people that we trust in life may not be professionals, they may not be family members, they may be members of the community, they come from a range of sources. So next, please. So trusted adult support reduces harmful outcomes. So this is in a way, the most important one, because if there was no evidence for what the Mark Bellis's research was picking up, we would be kind of in a fog. We wouldn't really know where that was coming from. But when we looked at studies, these are just a couple of examples, we could see that. For example, Hughes et al. Look at that, trusted adults and mental illness outcomes. And amongst those who'd never had a trusted adult relationship, 55.2% reported lifetime mental illness, in comparison with 31.5% who said they did have a trusted adult relationship. That's an incredibly significant gap there. That's, in the experience of these adults, even though they're all in childhood experienced these difficulties, these ACEs, their outcomes were buffered by the presence of someone they could trust. Next slide, please. But what are these core qualities? And I think these are no surprise. Whitehead research looked at an overview of these, said you have to be genuine, you have to be empathetic, you have to be proactive, which is interesting, not a passive relationship, but you have to kind of help that young person, with by going there, by being there, by asking them questions around some of the issues that Cian was raising, but also being confidential and reliable and non-judgmental and patient in how you are with them, in those qualities that you bring to the table. And Pringle et al. Have summarized these in a larger number of things, items which, do the same thing. Although one of the interesting ones here, I think, is being a positive example. So if you provide a role model in terms of what you're doing, that young person may, also follow that in terms of, you're the football coach or something like that, and it gives them a strength that they might build on, and it may, use you as their model as well as their confidant through that process. Next, please. But key thing is, I think, and a challenge to services is a lot of services are overwhelmed. If you're working in Tussle as a social worker, you're overwhelmed with people wanting your services at the front door. And therefore, most of these, of how people are responded to is within time limits, because you cannot have people in the system too long, or the system will completely grind to a halt and you won't be able to admit new clients through your doors. So time limit professional services, while they can be very effective, as we've seen with the Daughters of Charity, we don't know if those effects are long-term and last into adulthood and have impact on your mental and physical health. We don't know. It's likely, I think, that a combination of things is what people need. They need these long-term relationships who are not professionals, but at times in their life, they also may need professional help as well, which are more short-term and limited, but they're all of a piece, so that when they come out of those short-term and limited interventions, there is someone there to pick up and say, well, how did that go? And does that help you? And to build on that in terms of the relationship, which needs to be consistent, and the adults need to be committed. There needs to be like an emotional safety net, in a sense, provided by these adults. And people who feel overwhelmed by their unstable family situations need to be able to go somewhere or have someone who they can see as that anchor or rock, or that reference points that won't move, or is not a variable, but it's a constant. Good quote here from this young person called Anna, in the context of numerous changes of social worker, this study. I really think that they should try and keep that same social worker with that child for as long as possible. So then a relationship can get built up, the trust can get built up. So how many social workers, for example, working with young people in care, how many changes might that young person experience, particularly when they move placement? If you go from a residential facility to a foster home, does that mean you go to a different team, a different social worker? I think what this young person is saying is it's a relationship that should travel rather than a category that binds you within the organization. Next slide, please. And as I said earlier, these can come from a range of social workers. So, when we think of where we're at in terms of providing services, we often think of ourselves providing that, the social worker, the foster care, the teacher. And some of those professions are better placed to provide longer term input than others. Social workers, not so much, I think. But if you're a school teacher, you have that child for at least a year usually, and then you're probably in the same school after that, and so on. Together, and it gives a bridge into maybe going over the worst of times with that child and being there for them. And a lot of the guy, I can't remember his first name, Wright, the English footballer, I remember him talking, he had a very disruptive family life, and he was thinking of giving up football, and he was very disruptive when he first became a footballer. But I remember him talking television about, with tears in his eyes actually, about a school teacher who had been his reference point through those years. Mr. Pigeon, he was called, I remember that. And this guy, Wright, crying on the television when it heard that Mr. Pigeon had died. He died at in his 90s. And he said he got him through. He made the difference in his life. So when you talk to adults, sometimes people give these examples, and they're absolutely crucial. But these may equally be extended family members or other people in the community that we wouldn't think of straight off. And of course, signs of safety, the assessment which is used in TUSLA, does identify as part of its assessment other people in the family and community who may be built in a strength. So some of this, is reflected in our assessment that we undertake. Next slide, please. So we've heard, I'm not going to go over this again. We have talked about trauma-informed care here, and I think that it's trying to get these issues or these insights from research embedded beyond professionals. I think professionals now, as we've seen from Jigsaw and so on, have really taken on board this idea of what's wrong with you towards a more empathetic question of what has happened to you. So professionals are at that level, but are other people in the community, our school teachers, our community football coaches, is that knowledge filtering down? Is that approach filtering down? Because it would be very beneficial, I think, if young people were seen as not problematic, but suffering from problems. If that shift can take place, I think more generally, I think then you're onto a winner in terms of the number of people we can bring in to help such young people. Next slide, please. So a couple of final slides. What can we conclude? Well, young people living in situations where they face parental alcohol misuse and other adversities, I think, will likely benefit from having one trusted adult. And that gives us something we can work towards. How might that be provided? It's unlikely in most cases to be a professional. However, professionals could be involved in the identification and recruitment of this person. And I think myself, and I don't know what other people think, a short training in trauma-informed approaches might be beneficial for, both communities at its widest sense, as well as professionals who've largely taken on board this perspective. I think it's one more slide, please. Thank you. So I generally, when I'm looking at these issues, I try to really posit in the terms of, we are social beings. Our very health and livelihood is dependent on others, and when that goes wrong, in terms, particularly during our developmental years, it becomes highly problematic to us. And the paradox is that the sources of harm are in the same place as the sources of help. So it's human relationships, but the early harm in experience of human relationships affects our ability to accept the source of help from other humans, as it were. And it's very, very difficult to do that. But human relationships are the key in the repair process, but it has to be acknowledged that that is where the harm came from as well. And I don't know whether many of you saw that RTE documentaries on some months ago about homeless people in Dublin, and I think I covered other cities as well, but I remember Dublin particularly because I knew a lot of the streets, and I actually recognized a lot of the people who were on the program. And interestingly, they all acknowledged their background is traumatic and difficult, and what they'd been exposed to, and then what had happened to them in their lives, their addiction to drugs and alcohol and so on. They acknowledged that. What did they want? They didn't so much really want the euro in their paper cup. They wanted people to acknowledge them as human beings who passed them, get to know them as Joe or whoever. And there were some fantastic examples I remember somebody like, guy was outside a spar shop, and every day the woman came out and gave him a sandwich, a cup of tea, but also had a chat with him. What were you doing last night? What were you doing last night? As normal human beings, having an exchange, even though one was clearly more vulnerable and needy than the other. He wasn't being treated in that way. And I said to myself, how many times have I walked past him, that guy, I recognized him, and others like him? And really what they're wanting primarily, they need the euro for the overnight, but they really want that human relationship, and they want that repair. And it's people going past it, ignoring them, reinforce, if you like, what they've experienced in early life. And so people reaching out who are actually making those connections, which will be helpful in the long run. I think that's me. Thanks very much for doing the changes there, Sheila.
Thanks a million, Trevor. That was excellent, really insightful, and sort of strengthened the case for looking at it from a trauma-informed point of view and the trusted adult. I'm going to move quickly on to Fiona Coyle, who's the CEO, just to give us her reflections on what she's heard today. CEO of Mental Health Reform. It's been there since 2020. Fiona, I'll just move on quickly because our time is with us.
Yeah, and it's no easy feast, I think, to reflect on the richness that's come across in all the presentations. I think what really struck me as maybe a running theme across what everyone is saying is the need for us here in Ireland to reframe our approach to young people, I think more broadly, but in particular to children and youth mental health, that we're really move towards placing a young person and their needs at the centre, and really looking at identifying, based on evidence such as, what Christa outlined earlier around, the kind of alcohol misuse side, other kind of other harms, of how we can target interventions long before mental health issues escalate. That really means a broader approach. And while there is a lot of great words and policies, we're still not quite there in Ireland. Like, our policies really look at the detriments of health, the interconnectedness of factors like alcohol on mental health, that it's not just about the clinical services, but also about, addressing those social, education and economic detriments. But when we look at the services that are there, what's funded and how they're set up, we're still very much focused on, at the moment we know 2% of our youth population will need more specialised services, and we know those services in themselves aren't working, but there's often an over focus at that top piece of the pyramid. And we need our challenges. I think what's really come across is, Trevor was saying, we need a combination of options. We need to look at social work, we need to look at education, we need to look at, the services that are being provided in more health contexts. And I think that is our challenge here in Ireland at the moment, is how do we reframe how we're approaching young people? Because it's going back to what Cian was saying, the approach we have at the moment, it probably is still based on a more medicalized model, and it's making young people feel like, what's wrong with you? What's your diagnosis? How can we help this diagnosis? Rather than coming to them at the point where you can have a discussion about what's going on in your life. Life is complex, there's different options there to support you, and really investing in those support networks around young people. But we know, I think the reality is, our mental health sector, our children and youth mental health sector in particular, is very fragmented. We have a lot of different actors across healthcare settings, across schools, across the community and voluntary sector, across TUSLA, across the HSE, and they're all, I think, doing really good pockets of work, but there's very minimum coordination. And I think that fragmentation, as shown in lots of different reports, can often lead to people falling through the cracks. We're not connecting the dots. We're not going, okay, we're a country that has an alcohol problem, that the evidence shows that has an impact on our young people. How can we support those young people? Everything is kind of done in isolation. And I think, as far as mental health reform, one of the pieces that we've been calling for many years, is this initiation of the Youth Pathfinder project. So this Pathfinder project has been in the works for many years, but it was kind of a proposal that came out of the Youth Mental Health Oireachtas Task Force, that was a way of bringing together the various government departments and agencies that are working in supporting young people and their families, and bringing them together to really properly triage how we can help and how we can, you know, we have limited resources as a country, but we need to use those wisely to assist young people and to assist their families. But unfortunately, the Pathfinder initiative is still in draft. There was no money once again in this year's budget for it. But I think that's our challenge, is how can we reframe a way, and this webinar I think is very aptly titled around, you know, connecting the dots, because we haven't done that. We've done it in our policies. We say all the right things, but in practice and in that really cultural norms of different organizations, different government departments, different agencies, there's still a very strong siloed approach there. So, you know, I think we really need to move away to build a more connected, supported range of supports that puts young people at the centre and is meeting them where they need their support. Yeah, so I'll leave it there, because I know time is short and we want to get to have more questions and reflections, but I think connecting the dots is really key to all of this.
Thanks very much, Fiona. I might beg the organisers' indulgence, maybe take an extra 5 minutes at the end if you don't mind. I think it'll be worth it. Maybe just with that joining the dots piece, I'll just put it open to the panel. Anyone who wants to come in and say, listen, where can we see two dots that can join together? Can we is there easy wins to be done immediately? Just any, either Christa, Cian or Trevor, or even Sheila.
Can I just jump in actually there with a particularly easy dot that maybe would be out there. So TUSLA and HSE have a very good strategy. It's called the Hidden Harm Strategy, which is actually bringing their two organisations together to try and look at this. And they have provided training which is available on this, and it's relatively short, can be done over a day or so. And I think firstly we'd love to see a massive rollout of that across both the HSE and TUSLA, but I think there's real scope for that same training to be made available to multiple other people who could be in this field. So teachers would be the one to begin with. I would of course love to see teachers having their own training in initial teacher training, let's say, and I think that should be a part of it there. But just as a quick first step, that might be one that I would suggest.
Okay, great. Any other comments?
I think now, just in terms of, this might not be a quick win, but I think what we need to move towards is reframing that narrative among the public, among decision makers around investment rather than cost. We're all very well aware of all the dialogue around the health budget and the health costs, but when it comes to young people in particular, this is about investing in them. And this week in the UK, Bernardo's launched a really interesting study that looked at investing in young people and how every pound spent in a young person in terms of activities in the community. So, that type of community work, trusted peers, teacher support, everything that's been coming up, I think, in Trevor's presentation in particular, that would save nearly twice as much in terms of looking at the longer term mental health difficulty. So, I think as people in this space, that we need to collectively start changing how we're talking about investment as well. This is not a cost. We are investing. We are saving the country money in the longer term, while also, ethically and morally addressing the needs of the young people. So I think that would be something I would urge us as a collective to take forward.
I think it's a hugely important piece, because that if we remember through the height of COVID, that's what Mike Ryan was constantly telling us about, was this is an investment in our population. It's not a cost to our population. Mike Ryan is the deputy director of WHO. So I think that's really, really important. And maybe I might Trevor, I might come to you directly, just because I do think what you've done and Cian has shown it in practice as well. We do need to move towards the positive framing of all this. That's part of the narrative Fiona's talking about. If we can start talking about the child who has problems, or whose problems are around him or her living in problem situations, that takes a lot of the heat out of
Mm.
the old arguments about he's problematic or he's the problem. Can we build on that, Trevor?
Yeah, I think we can. I think in terms of joining the dots, one thing I've observed over the last 5 or 6 years, I think, at events like this, is that there's a similar narrative evolving around understanding where problems come from, and I would say it's more based on a public health evidential approach more broadly, yes, studies and so on, rather than a positional approach, representing a psychological understanding or a biological understanding. These oppositional approaches tended to meld into kind of the sort of psychosocial kind of economic model that we all buy into now. For example, you just referenced, a euro spent now will save X in the future, and James Heckman got his Nobel Prize for proving that. I think it was $1 spent now saves 7 in the future, something like that. So our evidential base has really, really grown and developed. That doesn't always do the trick because it has to be accepted. And I think we're at phase 1 of the acceptance, and that phase 1 of the acceptance is, and I may be wrong here, or maybe over optimistic, but it's been acceptance across at service level and in professionals in the field. People are using the same terms and are buying into the same narrative, which has created this fundamental change about what happened to you and then how we can buffer and mitigate. But I think we're in the early days of understanding effective buffering and mitigation, is the way I would put it, But I think there are very real clues here around traditional services. They're playing their part. They're doing good stuff. And we don't want to, replace those, or we may change how they operate, but we don't want to replace them. But we also, I think, need a much broader societal community-based approach around, linking people who have become decoupled from positive relationships. And that we're talking about young people here, but there are other people in the community, like older people, who that happens to as well. But it's the same effect. They became despondent. They lose years of their lives. You can see it in the Irish longitudinal study in aging. It's the same issues, where if the impact on the human, developmental is particularly difficult in terms of the challenges, but it also is, these potholes exist for us all. Because I've got to this age and stage doesn't mean to say that I may not be impacted by future events in my life. I don't know, but it's that idea of looking out for one another, which I think in Ireland we should be. We're past the stage, aren't we? Hopefully, where we tidy all the problems behind high institutional walls, and we acknowledge that they're out there, and that is really up to us to solve them. In terms of, and we have very, very significant strengths in Ireland that we shouldn't lose, because our communities are generally a lot healthier than some other countries. I was interested just in Christa's looking at Ireland's slightly higher races, but our outcomes are much better. If you look at the United States in terms of number of people who go to prison or have mental health issues or poverty and so on, much, much higher. So we mitigate and buffer by other factors in our culture, whereas other countries may not have those. So, you have to read these things in a sense of knowing the whole picture. And our whole picture isn't bad. We redistribute quite a lot of tax through our welfare system in a way that is redistributive to higher levels than most other European countries. That's good. Need to build on that. But we also need to build strong communities, and we also need to build very particular relationships where we see people being disadvantaged or isolated. And this, we're talking about young people in this scenario, but really that applies to anyone. So I went on and on there. Niall, that was...
That's all right. Thank you very much, Trevor. I'll just, Cian, any thoughts just on join the dots, and I'll ask Christa the same thing when we'll wrap up then.
The only other, a few things come to mind, but the main one, I guess, that we're trying to implement in services is trying to connect dots across services, fluid communication, not working in silos. So the likes of Jigsaw, primary care, CAMS, all working on the same page and linking in more. I think that's where we need to get to when trying to support young people who are experiencing high levels of distress. I think for too long the referral has gone to all 5 services at once or whatever, whereas we really need, and people are kind of batted from one service to the next. You know, we need to have kind of joined up dots with our communication, and you know, a kind of a platform where services can operate on the same level would be ideal. It's worth working towards.
Yeah, I think that'll be a huge step forward if we can get that sort of cooperation and collaboration. But I think it shouldn't be too far away either. So thank you very much, Cian. I think the other piece from your piece for me is certainly that idea that we need to talk about the macro, where the power is held and where the narrative comes from. You know, that the alcohol sales and where they attach themselves to, and the attractiveness. We need to challenge that power as well, I think, as well. Christa, what would your thoughts be on that?
Just to say, maybe helping others to connect those dots as well. You know, I think a lot of that stuff is kind of cloak and dagger, held under the wraps, and you know, we don't kind of demystify those connections in public. We don't want to talk about it, whereas those damaging pieces that are kind of going under the carpet need to be put out in the open a bit more as well, I think.
Okay, thank you. Thanks so much, Cian. Christa.
I don't have any additional ideas to add. I think that everything that's been said so far is great, and I'll add a little bit to the experts of the steps to do at this time.
Great. Okay, well, thank you for that, Christa. And again, maybe just there's one of the comments that are in there is the concept of maybe a public publicity campaign around the idea of a trusted adult or one good adult. Because I do think, as Trevor was saying, I think our communities are understanding ACEs now. I think we have sports coaches, we have people in drama, people in music who understand how to deal and be kind to children and to recognize these issues. So a little understanding on further on how they can help, that sort of hidden harm perhaps training would go a long way, I think, because we have those connections in many of our communities around the country, parishes, sports halls, wherever it would be. I think if people had access to that sort of training, it could really make a big difference without a huge investment. But I'm going to wrap it up there, Sheila, if that's okay. I think people have been very patient and hanging on. I really appreciate I want to thank all the speakers and Fiona for coming in at the end. I really enjoyed it, and it's really been powerful for me to hear what's been said. Thank you very much, Sheila.
And thank you very much, Niall. You just held us together really, really well there. Thank you to everybody in their comments in the chat box. We're definitely listening to those things. This really helps inform us in our advocacy and the ideas that we're putting forward. So just to thank again all of our speakers, thank you. And just let you know, we have another 2 events this week, one tomorrow in person in Buswell's Hotel, Triple Trauma in the Home, which is looking at mental health, parental problem, alcohol use, and domestic violence, those 3 things combined, and a last webinar on Thursday, Invisible Victims, and you can look out for those on our website. We'd love to see you back. Thank you very much.